Welcome, everyone. We are very lucky to have the experts. You know very well Bill Levin from New York. He was the president of American Shoulder Society. Marc Frankle from Tampa, who is now president. And Gilles Valch, you know very well from Lyon. He's a famous surgeon of shoulder and shoulder arthroplasty. John Sperling from Mayo Clinic. And thank you for your advice on GD from Paris and me from Paris. We have now 100 people who follow this shoulder board, and we had 250 registration. This shoulder board could be interactive because you have the possibility with the chat. We have a polls, and we have to vote because after the presentation of the one case, I suggest you some option, and you can vote. And we try with GD to answer to your questions. So I start with one case, and after GD another case on the last case, and we have 1 hour. Okay, this is a 46-year-old. This is a right dominant. He's a sportsman, and he was operated in 2017 of reverse arthroplasty for chronic anterior dislocation. And now I saw the patient in March with a painful shoulder on limited range of motion with forward elevation 100 degrees. And you see that the function shoulder value was 50% and the constant score 45. It was a painful and limited shoulder. And you see the x-rays. It was a reverse prosthesis because the surgeon decided to do reverse because no subscapularis, chronic anterior dislocation, and he decided to do the reverse. And I saw these x-rays with painful, and you see that the imaging on the glenoid, the imaging here, and I did a CT scan. On the CT scan, you see that on the glenoid, there is a doubt regarding the loosening. If you want to summarize this patient, this is 46, active man, no sign of infection. I did just after the consultation a punction to ultrasonography and it was negative. And you have these x-rays. And it's limited, he's a young guy on painful shoulder. You can vote, and after we ask to the expert. So first is an evidence that this is a loosening. And what are you doing? Do you do a new reverse with glenoid allograft? Do you decide to do 2 steps or bipolar allograft? Or do you decide to do in a custom-made reverse prosthesis?
You say that there is a humeral loosening?
I don't know. I have only this imaging with the CT scan and with a painful shoulder on limited range of motion. And I think that I wrote that it is bipolar because I saw here, and I saw is this imaging, and when I did rotation of the arm, the patient was painful, but I'm not sure regarding the humeral loosening.
Do you have any X-ray done before just to see if there is subsidence of the stem or not?
No, I have a CT scan. The patient was operated in 2017, and I saw the patient in 2020, and with these X-rays, only these X-rays and this CT scan.
And how do you explain unlocked anterior dislocation in a 44-year-old man? What was the clinical history to explain a locked anterior dislocation?
Yes, it was very strange because this is a patient who is a special educator, and he told me that he stayed in anterior dislocation during 3 months, and after he decided to visit the surgeon. I was very surprised about this patient, but he described this clinical aspect. I don't know why. He tried to reduce himself on his stay in chronic. It was the summer, and he decided to visit after the summer the surgeon. It's a strange story, but
yes,
it's like that.
When you say special instructor, is there any alcohol problem or dementia or something? Because
No, I don't know. I don't know.
and did you see any X-ray done after the prosthesis?
No. I saw only these X-rays. I have no X-rays between 2017 and 2020. And it took me that during 1 year or 2 years, it was nice. And after, he missed forward elevation on painful shoulder. So maybe, Bill, what are you doing for this patient?
You know, I have a very conservative approach to these types of patients. And although you said you don't think there's any signs of infection, I'm going to presume that it's infected until proven otherwise. He has, you know, it may be that he had so much anterior glenoid bone loss because of his anterior lock dislocation that the surgeon started out behind the 8 ball and didn't realize that by the time they did the primary reverse. We don't have a lot of the details, but my plan for this would be to do a 2-stage revision. And I would do so for the following reasons. Number one, it will give us a chance to rule out infection. And number two, and I would put an antibiotic spacer in on the humeral side. And number two, I can't tell how much glenoid bone loss there is, but there is a chance we might need to do a custom base plate glenosphere construct. And it's very hard to almost impossible in at least the system I used for that particular problem to get the CAT scan and do the reconstruction with the metal implant in. So it would give me a time to A, take a look at the shoulder, B, decide if I might need to do a custom, and C, treat the presumed infection. And if it's not infected, then we could proceed with our second stage. And that might not need to be a custom implant, but we'll know more after we have all that data and information. So that's how I would proceed, Philippe.
Okay, Marc?
Jill's comments are really important. You know, when I've treated maybe about 40 patients with chronic locked anterior dislocations. And so if you look at their characteristics, they generally have health issues that are outside the norm. They're either substance abuse or some limited functional capacity mentally. They might have some mental, intellectual, executive function problems, or they have some variant of Charcot arthropathy related to some cervical spine issue. So none of those things would really alter, but I think those things should be investigated because, you know, if you don't understand, well, what were the features that led to this, you might find yourself, irrespective of the degree of reconstruction ability that you were able to perform, an outcome in a patient that is not able to either be compliant or have insight about what they're up against. And lack of insight is problematic because, you know, this guy had some other surgeon treat him. We don't know what that happened. We don't have the original things. We don't know much other than he shows up like this. And, you know, he's not a really good historian. I start worrying about his social ability to be compliant and thereby impacting it. So having said all that, I think that's important. But now if you just talked about the reconstructive options and you figure out, okay, we're going to manage this the best we can. The next thing would be, I would probably try to do a 1-stage reconstruction. And I would hope that by using a screw-in base plate, I could identify the security of my fixation intraoperatively, because the amount of bone loss isn't as helpful as the ability to get primary fixation with the implant.
So you would treat him like an infection and take samples?
I would, in all the revisions that we take samples, my experience with this implant in particular is they're not infected, they're loose, and there's bone loss. I've revised a number of these because this is an Exactech implant, and in Florida, we you know, that's not that uncommon. Interestingly enough, I think I've revised more of the augmented base plate. I can't see if this has that than the regular ones. And there's not really much in terms of the ingrowth surface on the humeral side. So my experience would suggest that if it's not loose, it'll be easily to remove.
Okay, Gilles?
First, I would try to understand what is the problem, why this patient is like this at 45 years old. It is uncommon to have locked on chronic anterior dislocation. It is uncommon to have reverse prosthesis in this age group for an instability. So first, I would try to understand everything from the beginning. Then, if you have to do something because there is clearly a glenoid loosening, I'm not sure about the humerus, but for glenoid, yes, there is a loosening. I agree with Bill because I have never seen such a loosening after 3 years, even in the very active guy with such a osteolysis, bone loss, and so on. So I would assume that he has infection, and I would do a two-stage revision. First stage, I would not use antibiotics spacer. I would use pyrocarbon spacer. I like that, and it's very well tolerated for the case with infection. And I would do the second stage probably 6 months later to wait for more than 6 weeks as recommended by the infectiologist. So I like to delay the revision as much as I can for those cases.
And with the pyrocarbon in, you can do 3D reconstructions of the CT? Or?
Yes, yes, we do. Yes, we can.
And you, John,
Okay.
what would you do?
That's interesting. I've seen a number of people sent to me now with an excessive amount of inferior tilt, like you can see here. But this is just not inferior tilt. There's also a large amount of associated bone loss. So I agree with Bill. What I would do in this case, I would remove the components. I would put an antibiotic spacer in there. And I probably would get an MRI of the patient's neck to make sure they don't have a syrinx or another reason why they're having such destruction of their shoulder. And then based on that, I would do the reconstruction either with a custom glenoid component, or I had a case yesterday where a surgeon put this in an excessive tilt, and I actually took an augmented base plate and dialed it inferior to be able to go ahead and do that, to be able to reestablish some of the neck. So my lean towards what Bill's suggestions are.
Do you think that sometimes if you use a prosthesis without any offset on the glenoid side, the risk is to develop a glenoid notch? Is it not possible to have a mechanical problem for this guy?
I would just say, looking at it, it seems that either, that's why the preoperative x-rays would be great, but it just seems that there are some surgeons that excessively ream the glenoid in the amount of medialization and tilt, and I've seen that before. But this, when we look at the CT scan, there's so much bone loss that extends almost up the glenoid base plate, I believe, from that CT, that I'd be concerned that there's another process going on.
Yeah, Philippe, can I make a comment? I just revised a patient like this last week. And to me, I think what has happened is that the entire glenohumeral joint has been eroded into the medial scapula. If you look at that little inferior bone, I don't think that's a notch. I think that's his native glenoid. And I think what's happened is he's been pile driven into the scapula, and the entire thing is pushing and eroding the bone behind it. I think that's what's happened here, and I've seen several patients that has happened to very recently.
Okay.
I would just make a similar comment. With these locked constructs where the screws are locked, the mechanism of failure is not through breakage, it's cavitation, because the entire locked construct now acts as something that can erode the glenoid. And so you see that ballooning.
And I have a question. For this case, you have a clear problem on the glenoid, so probably this patient will undergo a revision. But sometimes you have a painful shoulder with limited range of motion with the reverse, and it's not very clear whether there is a loosening. And so the first step is typically an aspiration. And do you do that aspiration? What do you do with it? Do you routinely scope them for samples or in front of a painful shoulder?
I send them up for ultrasound guided aspirations, GD.
And if this is negative for you, you rule out infection?
That, along with the blood work, which is not great, but also it's based on the clinical appearance. If you have a loose humeral component, it's considered infected until proven otherwise for me. So
Okay.
early humeral loosening that way. And then again, seeing that preoperative x-ray on the glenoid, what's happened over time. So putting the clinical picture together, x-ray, with the lab studies.
Maybe I show you what I did, because I consider that the patient was very painful, and I decided to do a new prosthesis. I remove, I use a deltopectoral approach. I remove very easy the glenoid component because it was a very big hole. And I did 5 biopsies because Gilles told me many times that it's important to do biopsies if you have a doubt about the infection. And I decided to do in one step with allograft on the glenoid, and I put a small allograft here because I removed the stem because it was glenoid loosening. This is a cement here, and this is a graft. And I decided to put antibiotic with intravenous during 8 days. And after 21 days, I received the result of Propionibacterium acnes, but you receive the antibiotic during 3 months because the recommendation now for the infection in France is not 6 months, 6 weeks, it's 3 months. And you receive a B therapy of antibiotic during 3 months. And the follow-up was correct, and it is 6 months after the operation. And I saw the patient now.
In the meantime, there are some questions from the audience. Someone asks whether the excessively medialized base plate before could be a source of pain from impingement with the suprascapular nerve or plexus compression. What do you think about that?
Parfait. Très bien. Mettez la main derrière la tête comme ça.
Là? Ouais, ça, je le fais.
Comme ça.
It's the right side.
Ouais, ça c'est bien. Comme ça.
The question for Marc, I use a long peg, and I try always to put the long peg in the center
Tournez le dos.
of the scapula to have a fixation of 1 centimeter of the long peg. And this is a metallic lateralization, and I use a graft, but with the design of the prosthesis, there is a possibility to fix on the native bone. And maybe it was risky, but I think that if you do antibiotics and you have a suspicion of infection, if there is a problem, I remove all the prosthesis and I start 2 steps. But I would like to know your recommendation for your case, because if I understand very well, you recommend 2 steps. 2 steps. Gilles, you confirm that? You recommend
Yes,
2 steps?
2 steps for sure.
Okay.
Should we try to answer the question from GD regarding medialized glenoid, whether it's cause of pain or not? In my experience, we have seen many Gramont design with a severely medialized glenoid with severe notching, but this is not responsible for pain. So I don't think that we could say that the medialized glenoid is a cause of pain, postoperative pain. And yes, to answer to you, Philippe,
Yes.
in this case, I do not hesitate to do 2-stage. I would prefer to do autograft instead of allograft because this is my experience. But otherwise, I think that you did a really good surgery. That was risky surgery, but at the end, it's a very nice surgery. Congratulations.
And the samples were negative, Philippe?
No, the sample,
PFS.
PFS, okay.
Yes, it's the reason why he received antibiotics for 3 months.
Okay. And someone asks how you corrected the offset with such medialization and destruction of the landmarks.
I think it's very difficult, but for me, if you are able to repair the subscapularis, or if you have a good tension of the cuff, you can try to reproduce the anatomic lateral offset. And I think that you have to measure to do a planification, but it's very difficult with a prosthesis because the planification is not very reliable. And I think that for me, in revision case, I measure the lateral offset with the tension of the subscapularis. If you have no subscapularis, it's more difficult for me. Stability of the prosthesis is very important. And in this case, I try to do. But I asked to Gilles or Marc or Bill, how do you do to evaluate the size of the graft to reproduce a good lateral offset?
So how to restore what you call the lateral offset is a glenoid lateralization? Is that what you mean?
Yes.
To correct the excessive glenoid medialization.
Yes.
So yes, it's clearly important to correct this glenoid medialization and to lateralize a bit, meaning that you have to do more than the anatomic lateralization of the glenoid. I always try to do a little bit more. So, of course, in this case, you do not have a scan pre-op to assess exactly how much medialization you have to correct. So what I would do is I would think about the medullary, the vault of the glenoid side is about 20 to 25 millimeter. So I would consider that I need to have at least 25 millimeter of bone for the medullary canal and so on. And then I would try also to lateralize a little bit more. So that is what I would do if I do not have a CT scan or a correct X-ray assessment before the surgery. But I agree with you that it's crucial to reconstruct the glenoid bone stock, to lateralize the glenoid, and to rebalance the cuff. I'm not sure that you can really assess the lateralization with the cuff because the cuff is retracted and it's not so easy, but it is a concern for everybody, I believe.
And in this case, Gilles, it's chronically, the subscap's chronically torn after the first dislocation. So that's hard. And Philippe, that's really why I believe, I know I'm anxious to hear Marc's perspective because I know he wants to do it as a single stage. But for me, for reconstructing, that would be the value of doing it in 2 stages because we could really evaluate the CAT scan and then preoperatively plan where exactly we want to put the base plate. Where do we want to put the bone graft? What kind of bone graft do we use? Do I need a custom prosthesis? You showed us you don't need a custom prosthesis, but those are the reasons that I think doing it in 2 stages have value for the pre-op planning. But Marc, I'd love to hear your perspective on doing it as a single stage.
Yeah, as you might expect, it's going to be different from most of yours.
That's why we love you, Marc.
So my first comment is, when I'm revising someone that has excessive glenoid bone loss, or it's a primary procedure with excessive bone loss, my algorithm changes of what is going to be most important for me. So in cases like this case where there's excessive bone loss on the glenoid, a loose implant, my first priority is ensuring I get really secure fixation of my implant to bone. And ideally, I want to have my implant touching as much of the native bone as possible. And the only use of the graft that I would use an allograft for is trying to make sure that if there are portions of my base plate that are not covered, in other words, let's say 20% of the base plate is touching the post and 80% of the backside of the base plate has no contact, and I would use a graft to try to have complete contact of the undersurface of the base plate. But it's not to try to lateralize where the base plate is. It's trying to provide a backside that has a good amount of bone supporting it. So if it's loaded, it will not have the propensity to toggle.
Marc, can I just ask you a question? In this case, this represents how much bone loss he has. So where exactly if you put the DJO base plate in, if you put it in here, it would be way too medial.
Yeah, well, but and that can happen. But you know, my thinking has been with these cases. Again, I want to have that single center screw find a column of bone that will let me know confidently that I can reattach the implant and get it to be securely attached with some undersurface contact. And in fact, the idea of it being really medial is exactly right. So once I get the base plate securely attached, then the selection of the Glenoid I'll use will be somewhat dependent upon how confident I am of my backside contact. So if I'm a little bit concerned that my backside contact is 80% allograft, 20% host, then I'm going to use a Glenoid that's larger, that will allow me to have peripheral rim contact. It will be slightly medial. Some of those are slightly more medialized in terms of the center of rotation. But then I'll be more apt to build up on the humeral side. Because now it's a very different scenario than someone who I'm going for a perfect outcome. I think that where Philippe has his humerus idealized the tension of the shoulder, and I like the idea of trying to use some of the remaining cuff to get an idea of adequate tension, but you can get that tension by lateralization in any of the different ways. So I would approach this with some idea of changing my priorities, first trying to protect the fixation and trying to ensure it's stable, and then dealing with the soft tissue issue.
I would say I have another way I would view it. And I think what we've seen, a number of us, is the failure of using bulk graft. So Jerry Williams' paper from the Rothman Institute has a 25% failure on bone grafting on primary reverse out of the Rothman group. The Mayo group that Dr. Sanchez, my partner, looked at using graft for revision reverse of 25% failure rate, and some are late failures out 2, 3, 4 years. So my view is a little bit more towards Mark's view, where I would want to get metal in contact with bone, and I would either do what Bill said, get a custom glenoid in there, or use augments like our hip and knee colleagues do to make up for the missing bone. I would not count on dead bone getting between my base plate and the native bone to heal together for the success of the construct.
So I would just want to point out something, though, that the use of a graft to lateralize the center of rotation is one way to do it. Bio-RSA, allograft, right? So you can use an allograft prosthetic construct on the glenoid to achieve lateralization. And I use allograft, but I don't use it for lateralization. I just simply use it to have backside contact to avoid the potential for shear loading in the unsupported portion of the back of the base plate.
I agree with that.
So
I would like to do a comment regarding allograft, because I think that if you do an inferior tilt, you have a compression of the allograft. And in my experience, it's if you put with 10 degrees of inferior tilt with a compression, you have no resorption of the allograft. You have a resorption of the allograft if the base plate is vertical and there is a sharing forces. And in my experience, I have less than 20% of resorption back to the base plate. It's completely different than the humerus. In my experience, allograft in the humerus, the rate of osteolysis is bigger than the glenoid. But I think that depends on the positioning of the base plate in my experience. I don't know. Gilles, what do you think about that? Allograft?
I have a different experience. I do not like allograft. I do not use allograft. I know that people like you, like Pascal Boileau, have excellent results with allograft, but I remember also the paper from Marc Frankle with a bulky allograft of the glenoid showing that it does not work. So I'm not sure. I do not use allograft. So or very rarely. I wonder a little bit about the option that John and Marc propose, just to medialize or to lateralize just with metal, because if it fails, what happened? And you say that you observe 25% of failure rate with bone graft in revision arthroplasty. Yes, I agree with that. It's also about my rate. But what is the rate of loosening or failure of the case you did a reconstruction with metal? That is a question. We don't know about that.
We don't know. That's right.
I can say that when the most recent publication that we had was revision of failed total shoulders, and we had about 170 or something, and half of those failed total shoulders had substantial glenoid defects, and of those, I think there was about 7, so probably 6, maybe about 8 or 9% failed. So there is a failure rate, and if it's a large bony defect, for me, it's probably about 10% roughly.
How much?
10%. So, you know, my own sense of it is I've revised those 7 to another base plate, and I was successful. And in fact, I revised one of those recently, and the graft that I put in actually incorporated. So, you know, in one way, I'd say, well, that's a 2-stage operation. It just spread out over several years.
Maybe the second case.
Okay.
We're only going to get to one case, Philippe, with this group.
Yeah, you can see there's uniform agreement too, isn't it?
So I'm going to show you 2 cases in one because they're very similar to me. They have been operated on by 2 friends of mine, 2 different patients. One of the cases I've shown already to Gilles and to Philippe, and I don't have any idea actually of what really happened, and they did not have much idea. So I wonder what are your thoughts? So the first patient, he's a 75-year-old, and he came here for advanced cuff arthritis, what failed non-operative treatment. And the indication was a primary reverse for that patient. And this is the immediate post-op radiograph. So it's an internal rotation, so we cannot say much. But what happened is that at day 2, the patient dislocated with no trauma. The deltoid was fine, no epilepsy, no seizure, no whatever. The patient underwent closed reduction, but the surgeon did not manage to do that closed reduction. So he did an open reduction. Intraoperatively, he looked for version problems. Nothing was wrong. For impingement or whatever, nothing looked seriously wrong. And intraoperatively, the patient was stable. But immediately, postoperatively, the patient dislocated again. So he decided to revise that patient. And this time, he put a higher polyethylene bearing on the humerus, and he sent samples to the lab. The problem is that the patient dislocated again. And so he did some measurements compared to the contralateral side. He did a CT scan where he could see that the glenoid was slightly antiverted. He measured the version of the humeral stem, which was 23 degrees of retroversion, which didn't look too bad. And so he revised him again. And this time he put a larger glenosphere with an inferior offset and a humeral spacer. And now the patient is stable and is with a nice result. And the second patient is very similar. And I think it's nice we discussed both patients in the end. Again, this patient had advanced cuff arthritis. This one, he had a full passive range of motion, and he had an elevation lag sign. So he was pseudo-paralytic with an external rotation lag sign. So the surgeon decided to do a primary reverse with a lepiscopo. And this is the post-op X-ray. And I don't see anything really wrong with this one. And the problem is that at day 45, that patient with no trauma, no deltoid palsy, he dislocated also. And so these are the X-rays after dislocation. This one, he had closed reduction. Before the closed reduction, the surgeon did an aspiration of the joint, sent it to the lab. It looked like a hematoma, but nothing very strange. And on the fluoro, the patient was completely stable. And this was the radiograph after reduction. And the samples sent to the lab were negative. And this is him after 30 days of immobilization. I'm going to go quickly on this because the idea is just to show you that the patient was doing quite fine. So he had a good outcome, but the problem is that the story is not finished yet. And he dislocated again. And there he had the closed reduction, which was fine. And here it's again a video of him showing that the outcome was not too bad. You can see that either you believe in it or not, but the lepiscopo seemed to work. His hand was no longer in his stomach. But the next day after his visit, he dislocated again. And this time he had close reduction, but the surgeon decided to revise him, and he revised him for larger glenosphere, same, and a higher polyethylene bearing. Again, intraoperatively, there was no problem of version or impingement or whatsoever. And we decided to immobilize him this time in a custom-made brace for 6 weeks. And now he's 7 months after the last surgery, and he's doing fine, and he hasn't had any episode of instability anymore. I'm going to show you just a quick video, but the idea is just to show you that he's doing well. You can see that the external rotation is not too bad. And so these two friends of mine, they asked me my opinion at every single stage of what happened. And at every single stage, I didn't know what to do and what to tell them, because I don't understand why these patients dislocated. So maybe, Bill, if you can help us understand what happened, or if what you would have done differently.
Can you go to the
Sure.
to the first post-op X-ray of either of the patients?
So I'm going to show you the one that is in neutral rotation because we see it better. The only thing I see is that it's the same implant in both cases, but I don't know if you can tell anything from that.
Well, there's something, there are some patients whose, for whatever reason, their deltoid wrap, their deltoid tension is just not appropriate for a reverse shoulder replacement. And I don't have an answer for you, JD, as to why that is. And I don't know if it's implant design. Maybe some of the other panelists will give you that opinion. But there's something about these two cases that demonstrate inappropriate soft tissue tension. And so until the soft tissue tension was improved upon by changing the prosthetic design, in this case, larger glenosphere, additional length, etc., the multiple you may get one closed reduction attempt in your unstable reverse, but if you're doing it multiple times, then that's the definition of insanity, to continue to do the same thing over and over again. So the soft tissue tension was problematic from the start, and until we improved either the lateralization plus the distalization or both in these cases, we did not achieve a stable shoulder.
Mark, do you agree, or what do you think?
Well, for me, they're a little bit different cases, because I've had a similar case of after a Lepiscopo, the patient was unstable. What I actually found when I ended up I had two of them. So one patient I treated closed, and the thought was she had deltoid apnea, and my hope was that as she got further away from her surgery and she started to recover her deltoid function, then she ultimately got stable. And the other guy, he kept becoming unstable. And when I revised him, what happened was when he went to extra rotate from his Lepiscopo, the upper border of the lat actually impinged and drove his shoulder out. So it was a dynamic impingement. And so that was actually something that made me realize I really liked doing that procedure. But after that, I became aware that if you pull the lat too tight with the dual Lepiscopo, it actually could provide a dynamic instability that you would see in that case. So I would say that eventually, in the Lepiscopo case, by lateralizing and with the implant, might have reduced the dynamic impingement. So that would be the second case. The first case, the one thing I saw that got me a little concerned is, if you have an acromial fracture, you might not be able to get adequate tension on your deltoid, and I couldn't really see that on that first case, but it looked on that picture like the acromion was tilted inferiorly. So that would make me think that probably why that was so hard to tension was that it was hard to get the tension of the deltoid. Because
I think that was just the radiographic gantry perspective, Mark.
Yes, because here it looks fine.
Except you see that bone right near there, right? You near
It's
the
true.
acromion, right? So you might have had some detachment of the deltoid. Would be, that would be the other thing that would make you see that obviously there wasn't an adequate compression, as Bill mentioned.
What is the status of the cuff, GD? Subscapularis?
In the first one, there was no subscapularis, but in the one with the latissimus dorsi, there was a repaired subscapularis.
On the posterior superior cuff?
There was in the second one there was no supra, no infra, no teres minor, and in the second one there was a teres minor. But I was sure someone was going to comment on the lepiscopo, so this is why I put both cases, because if lepiscopo is an explanation for the second one, I don't really have an explanation for the first one. I agree that there's something seems to have been happening on the acromion, but the deltoid contraction actually was perfect. The patient is bigger than you, Marc, and he has bigger muscles than yours, and his deltoid seemed to work perfectly. And
if he's really large, JD, then you might have not gotten him lateralized enough.
That's the only idea I've had, but Gilles is going to say that he has been implanting Grammont implants for a very long time, and instability was not the greatest problem. So I really don't understand. And for the lepiscopo one, why would adding height protect from that lepiscopo effect?
Because it distalizes the humerus, so the upper border of the latissimus is farther away from impingement.
Okay.
Yeah.
And John, what do you think?
Yeah, the way I think about instability, it's either component malposition, soft tissue imbalance, or usually it's both. So I would have done exactly what you've done. Make sure with imaging studies the components are in a reasonable position. And I agree also with Bill. The idea of doing multiple closed reductions doesn't make sense to me as well.
No, I agree, but for the first one, it's not what happened. There was a first close open reduction actually, and then the surgeon revised him each time to change something.
I think
go ahead, John.
Just very briefly, there are people who have instability with reverse for reasons we don't understand. Bob Cofield had a patient who was a voluntary dislocator with a reverse, where he put it in so tight in the OR, he couldn't dislocate it. I saw her in clinic when he was gone on vacation, and she could purposely manipulate her scapula and voluntarily dislocate her reverse. So there are some people we cannot make stable.
So these two guys didn't look like these types of patients, but...
Well, no, what I was going to say, JD, is that, Gilles' experience is phenomenal, but the reality is that we all see patients in our practices that just don't follow the 95% rule, and they're outside of that rule. And when that happens, you're doing the right thing, and we're doing the right thing. We're trying to ask the question, why? And sometimes there's an answer, sometimes there isn't necessarily, but that's what we all try to do, because if you do the same operation the same way every time, then thank God the majority of what we do is successful. But none of us has 100% success rates except Marc. So I
just told you about my failure rate. Oh, Jesus.
So the two questions I have is preoperatively, do you have something that helps you to tension? How do you decide your tension for these patients? Do you try to restore the wrapping angle, or do you have something like that? Or because I know Gilles doesn't believe at all in that wrapping angle.
I agree with you and with what was said. Oftentimes, instability is a problem that we cannot understand. From one case to another case, it's completely different regarding the glenoid lateralization, regarding the neck shaft angle, regarding the lengthening. So I'm not able to tell the difference between lengthening and lateralization for stability of the reverse. We know that for the Grammont design, we used to lengthen the humerus and the patient was stable. So now we tend more to do glenoid lateralization to stabilize the reverse, but I have a series of cases with a huge glenoid lateralization and instability. Marc Frankle, at the beginning of his experience with a huge glenoid lateralization, reported a rate of 3 or 3% of instability. So that means that glenoid lateralization alone does not prevent instability. Lengthening a lot does not prevent instability. So I try always to understand and to summarize all the cases of instability I had, but I'm not able to do that.
So last question, if this patient with this X-ray, he has had 1 or 2 close reductions, he comes to see you, you know you have to do something for him. What do? Do you try to lateralize more, to distalize more? You don't really know what to do.
First, I do a comparative CT scan of both
Okay.
arms, and I measure. When you say it's the same length, I don't like that. You need to have at least 1.5 centimeter lengthening of the arm to have more tension on the glenoid side. To lateralize more, no, I would not think that lateralizing more will improve the stability. I would, in this case, I would prefer to lengthen the arm in order to have more tension on the deltoid side. Because I've never seen...
Your goal is 145%, that's what you said?
145.
What is your...
At least you need to have lengthening, at least 1.5
1.5, okay.
centimeter lengthening of the arm.
Okay.
But in case of instability, I'm not afraid to have 2.5, because I'm not aware of any paper showing that lateralizing the glenoid will prevent the dislocation. And
Well,
again,
I think
again, Marc Frankle has a huge lateralization and the same rate of instability.
Yeah, but I think that's not the question, Gilles, because as Bill said, the incidence of instability after reverse is actually quite low. So I think the answer is, once you have an unstable reverse, that question is now more germane of how you might manage that particular patient. Because if you just accept that there will be complications of any operation, no matter what you end up doing, there'll always be some failure mode. Then if it's a relatively low mode, you just accept that it's not necessarily preventable. But treatable is another situation. And I would agree that when you treat these, there is some good ideas about trying to understand what happened. So in both of these cases, there was some reduction in soft tissue tension or some soft tissue imbalance that led to the instability. The reason we know that is because when it was increasingly tensioned by larger components, it solved the problem. But, like early instability is deltoid F, and that might require nothing other than close reduction and reassurance until the deltoid recovers. And then the other thing that Philippe was alluding to is, when you look at patients that are unstable, there are those that have the least amount of rotator cuff. So if you have a large amount of cuff, you rarely see instability because there's greater enforcement.
I think that in my experience that if you do close, because you don't understand very well the problem of deltoid on the cuff, imbalance on the, sometimes if you reduce close reduction on immobilize in a cast during 6 weeks, in my experience, the reverse prosthesis is stable. I don't know why, but I think the retraction of the soft tissue adherences maybe participate to the stability of the reverse prosthesis when you don't understand. And I think many times I revise 1 or 2 times, and after I put a cast, and I am very happy. But I don't understand what happens. But is it your experience, John or Marc? A strict immobilization with a custom-made brace?
I'm a little less optimistic about the closed reduction. I typically, many of the people I see have had chronic dislocations by the time they get to me. And in those cases, what I've done is I agree it's a mystery. So I will actually increase the lateralization on the glenoid. I will actually go on the humerus longer. And then what I do is I get to the point where I can't reduce the shoulder. And then I have the anesthesiologist paralyze the patient 1 time, and then I reduce it. That's how snug I put it in, because I think there's a spectrum of tightness, and that's typically how I've done it. I've learned from Gilles over time. When we used to put him in super tight, now a little looser, it's acceptable. But that's my thing. I lateralize, distalize, think about a constrained liner, and paralyze the patient one time and put it in that tight.
But so, for example, let's say this implant does not have a lateralized glenosphere. You would remove the base plate and revise
No.
completely? Okay.
No.
Maybe
My
you
experience
can,
regarding the stiffness, Philip, my
Yes.
experience is that a very high percentage of my instability cases had almost normal passive and active range of motion pre-op. So I would advise to be very, very careful, whatever the etiology is, CTA, massive rotator cuff tear, or whatever. If you have a normal range of motion preoperatively, don't do a reverse because the risk of instability is extremely high.
okay. This is a woman. I saw this woman in 2019. And she's a rheumatoid arthritis, and she received corticoid since 30 years ago. And a surgeon did anatomic arthroplasty, revision, and synovectomy. And I received the patient, I saw the patient in 2008. And she did in 2008, he removed the implant and he did a resection arthroplasty. And during 10 years, the patient stayed like that, because she was operated 3 times before. But in 2019, she decided to saw me, and I visited in consultation. And when I did, I saw his X-rays. This is like that. It was a floating shoulder, and this is a CT scan. And she stayed more than 10 years like that. She told me that it was not possible to stay like that because they have no active, but less flexion of the elbow, less function of the hand. And she's a very nice woman, and she was very motivated to do something. But you see that I did CT scan, and this is for me like a resection arthroplasty, and what do you do? And this is many options. You see that arthrodesis, ME, 2 steps, 1 step, custom made, or reconstruction. You can vote, and after I ask the expert in this difficult case, because she was operated many times, any infection, and she received corticotherapy since 40 years, and she decided to do something after 12 years because the disability of the hand, of the elbow was very, very impressive. And what do you think about this case, John?
So for me, what I would do on this case, on the humeral side, I'm going to have to make up for the missing bone. I like to use metal rather than bone for that. And on the glenoid side, on the CT scan, I would make a decision, do I need a custom glenoid component, or can I make up for the missing bone with metal with augments? So that's what I would do. I would preoperatively aspirate her, of course, as well before I would think about doing that.
Okay, Gilles?
Well, do you have a CT scan?
Yes, a CT scan.
I need to see the glenoid bone stock and the muscle. For the glenoid, this is a 3D view, but do you have an axial cut to see the muscle?
There is no cuff, there is no subscapularis, there is only the deltoid.
Deltoid is normal?
Is
Looks
normal. Electromyographic study normal, deltoid normal, but she didn't work the deltoid since 10 years, but he's functional. He's functional, the deltoid.
So it's a typical case of resection arthroplasty after an infection, probably. And I would be very careful to propose any revision right away. This lady is 63 years old. She has rheumatoid arthritis, still active. So I would try to see on the axial cut of the CT scan whether I can do a good reconstruction of the glenoid, because even with the alternate center line that I learned from Marc, I'm not sure that you can find enough good bone to anchor something like this. So I really need to carefully analyze the CT scan and see the bone stock, the glenoid bone stock. On the humeral side, we know that there is no greater tuberosity, no lesser tuberosity. So
Yes.
that means that you will not have any cuff stability. So all the stability will be from clearly the deltoid tension. That means that you need to lengthen a lot. Lengthening a lot with a poor bone anchorage on the glenoid side is dangerous. So I would be very careful before proposing surgery.
You do 2 steps. You do reconstruction of the glenoid, and after the second step, Gilles.
It could be a 2-step procedure, yes, if it is possible to bone graft the glenoid and to implant hemi reverse, could be 2-step, yes. But again, to put a prosthesis is easy. You can always do that. But what about the results of this lady? So I'm not sure that I can give her better result than what she has now.
And how do you decide between 1 or 2 steps?
Well, I usually decide that preoperatively regarding the bone anchorage on the glenoid side. If I feel that this bone anchorage, there is less than 10 millimeter anchorage in the native bone, I do 2-stage.
Marc, what do you do for this case?
Yeah, I'm with Jill. This would not be. I would probably be very apt to want to talk this lady out of surgery. I think all the comments he made, I agree with 100%. In order to make that decision, I would need to have a lot of information, and I would need to be in the room with this patient. But revising a resection like this, these are so much more difficult because finding planes is tough, distortion is tough, and then you have bone that has not been loaded for a long period of time. And I think the likelihood of having a failure in this circumstance would be quite high. So that would be my concerns.
Philippe?
Yes, I know your answer, William.
Well, I learned a long time ago from some of my my mentors that there's nothing wrong with telling a patient, even when you're the world's expert, that you don't think that surgery can help them. And that sometimes is very valuable for a patient to hear, especially if they hear that from Professor Valenti, who says, I just don't know that surgery can help you, ma'am.
No, I refer the patient to Lyon, to Gilles, in this case. I prefer.
Oh, you can. I will tell her that I'm not able
No,
to.
I agree 100% with you. Depends of the discussion with the patient, because she stayed 10 years and she did 3 consultations with me before I accept to do operation. I think that she was very motivated, but now I'm not sure that I choose the good way, because I would like to show you the future. And I operated this patient and I was very happy. I did a big allograft post-operative. I did allograft to the glenoid, and just after the operation, I was happy. But I saw the patients 2 months after, like that. And I decided, of course, to remove the glenosphere and to put a big head. And to put a big head, and I decided to put bone graft to the glenoid. And the patient was not very happy, because I show you the video of this patient with hemi-arthroplasty, and this is a hemi-arthroplasty, and you see that?
Le coude.
Yeah, she's unstable.
Ok. Essayez de lever le bras en avant. Non. Ok. Mettez le bras dans le dos, par exemple. Ouais, ça c'est pas mal. Ok.
Very nice medial rotation.
Comme ça. Pliez. Voilà. Là, comme ça tient. Non, ça tient pas. Pas droit. Et avec le bras gauche, soulevez le bras droit. Voilà. Allez-y. Allez-y, 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 allez-y. Essayez de tenir en l'air. C'est difficile.
Mais je peux pas le lâcher, il tombe.
Il tombe. Ok.
Okay.
Philippe,
Yes.
congratulations. It was very courageous to do this
No.
surgery. And congratulations also to show these cases because,
No, because
we,
it's
always, we always learn more from our failure and mistake than from our success. So congratulations. It's very instructive for everybody that even if we try to do something fantastic for the patient, sometimes it is difficult to achieve a good result. So congratulations for showing this case.
And I would like to show you the operation yesterday because I did a new operation for this patient, Gilles. And I would like to show you. I operated yesterday and I put a cast and I did an allograft with a scapula, and I put a plate and I put 2 strap flex, and it was very nice fixation. And I did a cast for 6 weeks for this patient. And I operated yesterday, and I try now to expect a good future, but I don't know, and I would like to show you the result.
Philippe, at post-op day 1, this is fantastic.
I would just say,
I promise to show you the case in 6 months. I promise you, and
Philippe,
I send you the video of this patient in 6 months.
I would recommend you to pray at least 3 times a day.
Yes.
yeah, and I would say that is grossly inadequate, Joe.
Okay, John Sperling, how many times a day does Philippe need to pray? Do I hear 10? 15?
Guys, I have to go. Thank you very much for including me. Bye-bye.
Bye.
Thanks a lot for your time, Mark.
Bye.
Thank you.
Experts.
Thank you so
very
much, JD. Thank you, Philippe.
Thank you,
See in
JD.
1 month.
Thank you for coming.
Thank
Bye
you.
bye,
Thanks a lot.
everybody. Thank you so much.
Bye-bye.
Thank you, Philippe. Thank you,
Thank
Gilles.
you. Thank you. Thank you.